septal defect. You can have a defect between the ventricle and any other chamber of the heart. See, in membranous, it's between the right atrium and the left ventricle, that is, which is located here. And in the muscular, it is between the ventricles, so it will close spontaneously, and is also known as Swiss cheese pattern type of VSD. In inlet inlet type, there is defect is beneath the tricuspid valve, and in outlet it is beneath the aortic valve. So again, since it's a left to right shunt, it will have pansystolic murmur. It's a type of shunt murmur, and eventually there will be biventricular hypertrophy. So you'll have Calvert's phenomenon in the ECG. That is, you'll have R and S at V3 and V4 will be equal, and also increase blood flow to the lungs, so you'll have pulmonary plethora. Left atrial hypertrophy will also be seen, so indentation of esophagus can be seen. And if you see in heart sounds, apex will be normal. S1 will be, you can see S1 will not be heard because it's masked by pansystolic murmur. S2 is wide and variable split, and S3 will be seen because of it indicates CHF, because CHF will develop around 6 to 10 weeks. Alright, apex will be normal, and thrill, if you see the thrill, you can have third and fourth intercostal, left intercostal space where the VSD is located. Other than that, shunt murmur, pansystolic murmur will be seen. Flow murmur, ejection systolic murmur will be seen at pulmonary area, and diastolic murmur will be seen at the mitral area. Now another thing is that in case of severity, if it's more severe, S3, CCF and flow murmur will be even more severe. Now if the patient develops CHF at 6 to 10 weeks, he can develop Eisenmenger syndrome at 30 to 40 years. What is Eisenmenger will be dealt later. Complications, again it's the same thing, Eisenmenger's, AR, that is aortic regurgitation, tricuspid regurgitation, and VSD is only acyanotic heart disease which will develop into infective endocarditis, and for that you should give amoxicillin or gentamicin. And surgical is that around 6 to 12 months or 4 to 12 months you should give when you do surgery when the pulmonary blood flow divided by the systemic blood flow is more than 2, and surgery is more preferred than that of the catheter.